As I said yesterday, part of what we do at DriverCheck, our purpose, our why, is to create a healthier and safer world for all. One of the ways that we try to do that is to promote learning and education so we can be on the front lines of changes in regulated surveillance and occupational health to assume best practices. And so that's behind the empower bit. So I hope, again, that you're able to take some things away today, take it back to your teams, take it back to your leadership, discuss it, empower yourselves to change if you need to. Okay, so as we did yesterday, we have a great slate of speakers. Leading off the day, once again, our leadoff hitter, our fan favorites, we have Dr. Melissa Snider-Adler. For those of you who weren't here yesterday, didn't hear her bio, she is DriverCheck's Chief Medical Review Officer, as well as a practicing addiction medicine physician in Ontario. She's an expert in all things alcohol and drug testing related. She's been called to testify, to write reports, and to offer expert opinions on a number of cases throughout a whole bunch of courts, hearings, and arbitrations. It's a real privilege to have her here. She's a dynamic speaker, and today her topic is going to be medication mania. This is a real topical issue. We get a lot of questions on this, so I'm so glad to welcome her today and have her join us in this talk. Thank you. Welcome, Ms. Melissa.
Thank you. Good morning once again. Thank you. All right, good morning. So again, I get to be the one who is up and bright, and mornings are a good thing for me, maybe with the exception of post-reception last night, but I am still doing okay. So we are going to talk about medication today, and we're going to talk about medication that is prescribed and medication that is over-the-counter that people buy and use in the workplace. And I will give you a little disclaimer here that I may cause a little bit of anxiety for some of you, only because I think the way that we have been managing medications in the workplace has been, well, if the doctor says that they're taking it fine, and then they're fine. End of story. But we're going to kind of break that down a little bit. So I apologize in advance if that is what is going to end up happening. But let's look at what we're going to talk about. We're going to go through commonly prescribed medications that are more common, truthfully, than probably we realize from a prescription perspective, what some issues are with them from an impairment perspective, how we deal with them in the workplace, and strategies. So that's what we're going to talk about. So I'm going to make you guys work just to be sure you're awake here. So we have a question here. There's going to be an A, B, C, D, or answer. I'm going to read it out. I don't love to read my slides, but I'm going to because I want you guys to raise your hands if. So how often have you had to deal with employees using prescribed opioids, benzos, or other impairing medications in safety-sensitive workplaces? Okay, so A, this is not something that I deal with often. Okay. B, a few cases a year. Okay. C, a few cases a month. And D, very frequently or too frequently. We can put that any way we want to. Okay. All right, great. So a little bit all over the place, which is good. But at the end of the day, what I really want to know is how comfortable do you feel dealing with this, whether it's once a year or feels like, you know, every single day. A, I feel really comfortable. Okay, good. B, you know, reasonable, not too bad, maybe okay, I think, until I start speaking. And C, not as comfortable as I would like to be. Okay, so that's great. So we have sort of a little bit all over, but we're going to go through and talk about medications. So which medications are we talking about? We're going to go through that. But the first thing is that I want to put this out there, and if you go home with nothing other than this, prescription medications can be impairing. And they can be impairing even if the individual is using it exactly the way their healthcare provider has told them to. So even if they are supposed to be taking it twice a day and they take it twice a day, and they never ever take more, they're not abusing it, they have no, you know, there's no addiction here, there's no substance use, they're not misusing it, it's exactly what the doctor says, it can absolutely 100% still be impairing. Okay, so just that is the thing that if you go home with nothing else other than that, that is what is most important. And then we're going to talk about how we deal with it. So I put this here because I think that often we all think, oh, you know, there's no addiction here. They're not misusing it. They don't look impaired to me, like by my little checklist of impairment, which we talked about yesterday, you know, maybe not to use the word impairment, but that's okay. They look fine to me. I don't see anything. I think everything is fine. And they're good to work. The doctor said it's fine. It's fine. We are going to not take that for what it is and just that, okay? Because we really have to look at the whole big picture. So which medications are we talking about? I think if I were to say to you, what are impairing medications, most people would say opiates. We know opioids, we call them opiates if it's codeine and morphine and heroin, and opioids if it's all the other ones, semi-synthetics or synthetics. But the whole one we can call opioids. So we're going to talk about what those are, but I think most people can kind of appreciate that pain medications, you know, probably are impairing or of a concern in the workplace. Benzodiazepines are the other one. They often get forgotten about because they are not part of the typical panel for drug testing. So often people say to me, well, it's not going to show up in the drug test, so it's fine if they take it, right? But that's not true. As we talked about yesterday, drug testing is good for certain things, but it is not the be-all and end-all. And if somebody is misusing or even just regularly using a benzodiazepine, and you see something from a reasonable cause test, and their urine and or oral fluid or lab test, whatever you're doing is negative, that doesn't mean that there wasn't an issue to begin with of impairment because we just didn't test for it. So often people don't test for it, but it still can be a problem. Barbiturates are another one. Not prescribed as much anymore, but they can be. Some people use them for migraines, so we'll go through that. Non-narcotic pain medications. So this is the one that I think we put at the bottom of the list here, but really probably should be closer to the top. So these are things that people take that are not opiates. So their doctor will say, I'm not going to prescribe you Percocets or morphine or fentanyl because, you know, you're working, but I'm going to give you, and then they give them, you know, a whole host of prescription medications which can be impairing. So I will name them, but they may not mean anything to you. Pregabalin is one, or Lyrica. Baclofen is another one. Gabapentin is another one. These are very, very commonly prescribed medications for pain because doctors want to avoid opioids sometimes, but they are all impairing. Okay, so, and we're going to go through that as well. Sleeping medications is another one. People often will take medications for sleep because they're not sleeping so well. Now, having said that, sleep deprivation and not sleeping is impairing as well. So we have to sort of balance all of that out, but it is something to at least look into. If you're taking a sleeping medication and it's a long-acting sleeping medication, they're going to wake up potentially feeling groggy or kind of that hangover effect. And then there are a number of medications for anxiety and depression that are not benzodiazepines or other medications that can also be impairing. Seroquel or quetiapine is one really big example that is often used that can be impairing, even though it's not Valium, let's say. All right, so let's talk about what these medications are. Opiates. So what are opiates? They are almost always prescribed for pain. We as healthcare providers and physicians were overprescribing them hugely. Part of the reason why we're in our opioid epidemic is what, you know, we call it with overdoses, et cetera, and issues with substance use with opiates. And so that's come down a little bit from a prescription perspective, but that doesn't mean that they don't get prescribed still. It's overprescribed because it is, you know, when a patient comes in and they're in pain and they are really in distress because they're in pain, it's a very easy thing to do to write a prescription and say, here, just take this. You know, like come back in a couple weeks and just take this and this should help your pain. I'm not saying that all healthcare providers do that, but it is an easier solution to give a prescription for something than to really talk through what are all of the other reasons why you're having pain, what are the contributing factors, what other treatment can you do that is non-medication? You know, are you exercising? Are you doing yoga? Can you get into a pool? Are you doing meditation? Are you sleeping properly? How has your mood been? Mood and anxiety make pain worse. So, but all those things take time to discuss. All of those treatments are non-impairing. They would be great for people in the workplace, but often medications get prescribed first. So with opiates, there are a number of different kinds. They range from more or less potent or more or less impairing. I think we can probably all know that codeine, which is available over the counter, would probably be at the lower end, but not the zero end from an impairment perspective, and fentanyl would be at the top. I think that's something that we can probably all appreciate, but there are a whole number of ones in between, and that does not mean that codeine is safe. So there's long-acting versions of most opiates and short-acting. So sometimes somebody will say to me, well, they're on oxycodone. And I read that oxycodone only has a short half-life, and so after 8 hours or whatever, or 12 hours or whatever, I think they're going to be fine. But then I ask, okay, well, which formulation are you taking? And then it's the long-acting one that is meant to last for 12 hours, but lasts in the body for significantly longer. So you need to know exactly whether you're talking these long-acting versions or the short-acting versions, because they do have differences. And then with most pain medications, they're not just taken at night before bed. Sometimes they can be, but often it's throughout the day. So knowing when they're taking it and how often they're taking it is really important. All right, what are benzodiazepines? Valium is the one that most people know. Ativan or lorazepam is something that are often given to people who are having anxiety or panic attacks to be able to use when they're not feeling well at that moment to bring everything down. But there are a lot of prescriptions for benzodiazepines given where probably they shouldn't be. As a treating physician of patients that have substance use disorder, as an addiction physician, I will tell you that these are way overprescribed. I cannot tell you how many of my patients, and these are patients with substance use disorders, with known substance use disorders who are referred to a specialist for their anxiety or depression, are given a prescription of Valium during the day and clonazepam and something for night by their psychiatrist. So they are overprescribed. And really, when you treat anxiety and depression in a whole way, meaning not just medications, therapy, sleeping, meditation, yoga, exercise, all of these things, managing your thoughts, counseling, et cetera, all of that, they are way more effective than these what I call Band-Aid solutions. But yet, they are prescribed often, and many, many employees are using these and use them to manage them, whether it's their mood or their sleep or whatever it may be. So the issue is that they are addictive, they are sedated, they are impairing, and they are overprescribed. There are many other sedating medications, and I can't list all of them because there are just way too many. But often, as I said before, they are prescribed for sleep, they are prescribed for anxiety or depression, and for chronic pain. So even when somebody says, oh, I'm taking medications for pain, but they're not opiates, don't worry, like I'm totally safe with these medications, you may want to just dig deeper into that. Because I'm not saying they're bad medications, they work actually reasonably well for most people, but that doesn't necessarily mean that they're safe. So why is this an issue? Why is it an issue in the workplace? Many of these medications will not just have a short action. So similar to what we talked about yesterday with cannabis, where you may feel, if you're using it recreationally, you may feel high only for a couple hours or a few hours, but those effects can last significantly longer. We have the same thing with medications for a few different reasons, and we'll go into that. But these medications, as I said, sometimes they're long-acting. They are meant to last for 12 hours, or they're meant to last for 24 hours, because there are some that are meant to last for 24 hours. And so, kind of hard to take those in the workplace if we know they're going to be impairing, and they last for 24 hours, and the person has to take it once a day, and they have to go to work and do safety-sensitive work. So there are the after effects, there are the impairing effects. The other big thing to remember is that with many of these medications, and I'm not even just talking about opiates or benzodiazepines, even medications that are taken for anxiety or depression, when you stop them, may have withdrawal symptoms. And withdrawals, even though the drug is no longer in their system, that's why they're feeling withdrawals, are impairing. So for example, if you have a person who's on a medication for their depression, there's a whole host of them, Zoloft, Paxil, Effexor, those are all the names. Generally speaking, when they get to a stable dose of those and they don't have side effects, they're usually okay, like from a safety perspective. But then they decide, you know what, my depression's been good, I'm gonna stop my Effexor, I don't need it anymore. And they stop it, and let me tell you that those people have significant withdrawal symptoms. What are those withdrawal symptoms? Shakiness, irritable, edginess, inability to sleep, usually this zapping thing that goes on in their brain that I have no idea why that happens, but it happens to most people who just stop some of these medications. Well, now try to go to work and concentrate on your job that you need to do. You don't have a drug in your system. I can test you for everything under the sun and it's going to be negative. And yet there still could be impairment. So for a lot of these medications, withdrawal is a big thing, and that's just a minor one, because if we talk about opiates or benzodiazepines or barbiturates, there are even more significant withdrawal symptoms. So for opiates, we have things like sweating, shakiness, chills, inability to sleep, restlessness, restless legs. If it gets really bad, you have nausea and vomiting, profuse nausea and vomiting, stomach pains. So, all of these things, it's very hard to work and concentrate and be safe at work when you're experiencing all of that. So how do they affect the workplace? This is sort of what we talked about before, but this is the list, which you can see that if there is an issue with these medications affecting your memory, your attention, your concentration, your gross motor skills, or even your fine motor skills, all of those things have a role in the workplace. Now, the one thing that I do want to say is that we often think, well, if somebody takes it every single day, they are used to it and tolerant. So this is something I hear from many, many, many physicians. Well, my patient is tolerant, therefore they are safe. I hear that with cannabis as well. Well, they're tolerant to it, so they're safe. Let me tell you that tolerance to a medication, and I'll explain what tolerance means in a moment, but tolerance to a medication is not synonymous with lack of impairment. So whether it is any medication that we're talking about, if it's an impairing medication and it affects your brain, but you are tolerant to it. So what does tolerant mean? It means that I've taken something for a long enough period of time that my body is now used to it. I mean, that's not the medical way of explaining it, but that's really what it is. My body now doesn't have the same side effects that it used to have. So for example, somebody may start a medication and have a side effect of a bit of a headache or a stomach upset, or they just don't feel great for a few days. They keep taking it for a few days, and they become tolerant to those side effects. They tend to go away, and they feel fine. But when it comes to impairment, and it doesn't matter what drug we're talking about or what substance we're talking about, a person may say, well, when I take my cannabis, when I take my opiates, when I take my benzodiazepines, when I take my pain medications, I used to feel a little, dizzy or off or tired from it. I don't feel any of that anymore. Therefore, I'm not impaired. That is usually the conclusion that employees will tell us, but truthfully, that is often what I hear from healthcare providers. And I will always say, well, tolerance is totally different from lack of impairment, because you feel fine, but that drug is still going to your brain. It's still impacting your brain and the parts of the brain that deal with cognition, with concentration, with attention, with focus, with executive functioning, with all of the abilities and the things that we need in the workplace. So you may not have some of the impairing side effects that you had at the beginning, but that does not mean that you are unimpaired, completely unimpaired. And I'll talk about a couple studies that really, this one here, that really go through this and really kind of hammers it home that this is not just an idea that I have, but something that we can show. So this was a study that was done in 2021. I have the reference there, and I will be giving you the slides. So, well, I won't be giving them to you, but they will be available. So you will have the slides, so you can take down or take pictures, but you will also get the slides. So basically what they did in this massive Canadian study was they took thousands and thousands and thousands of people who had been in car crashes, and they matched them up with all of their health records, meaning what medications they're taking or had been taking, past and present. And they combined groups of people. So what they did was they looked at a whole list. Actually, I'll switch to the next pages for a minute because I just want to show you the list here. They looked at antipsychotics, benzodiazepines, opioids. There's a few other sedating medications that they looked at. I'll go back now and before I tell you about what they found. But what they did was they said, are you taking these medications now? And they broke down the specific group of medications, short-acting benzodiazepines, long-acting benzodiazepines, more potent opiates, less potent opiates, antipsychotic medication, et cetera. Are you taking those now? Okay, if the answer is yes, they go into one group. If the answer is no, then it was, well, is there anything in their medical records that shows that they used to take those medications? And if they did, they put those into another group. Okay, so this is somebody who is not taking medications now, but they used to take short-acting opiates, or they used to take long-acting opiates, or they used to take benzos, et cetera. And then there were people who aren't on medications and have never been on any of those medications. And these are only people that have been involved in car crashes, okay? So what they did was they analyzed all of the data, and this is thousands and thousands and thousands and thousands of data over a long period of time. And what they found was this. Whether you have been on your medication for a short period of time, meaning less than 30 days, or whether you have been on your impairing medication for more than 30 days, and that could be 10 years or 20 years or a year, where you would be tolerant to it, the risk is the same. And in fact, the people that are on opiates, long and short-acting benzodiazepines, were at higher risk of car crash when they'd been taking it for a long period of time. So what we call tolerant, right? They're tolerant to it. They don't have those side effects. They've been taking it for a long time. They're on a stable dose. These are, again, not people that we are aware that are misusing it. And they had a higher risk of crash than the people that were newly taking it. Now, the theory would be, well, if you were newly started on an opiate and you're not tolerant to it, you're not used to it, then your risk should be higher, right? And maybe they do have a bit more impairment or different impairment, but maybe they realize it, so they're maybe driving more cautiously, or they compensate for it, newly being on it. And then those who take it for a long period of time think, I'm fine, I'm good, I'm safe, I'm not impaired, I'm great. And they just go about doing everything the way they were. They're at higher risk. But then what they did, which was interesting, was they looked at this group of people who are using these medications now and compared them to people that were on them before. Because people will often say, well, maybe the people that take these medications are different than the control group who've never been on them. Maybe innately their brains are different, maybe for their medical conditions, all of these things are different, and maybe that's why they have a higher risk of car crash. Maybe it has nothing to do with the medication. So they compared taking them now to taking them a long time ago with respect to that, and taking them a long time ago, the risk was significant. So not meaning that you're at much, much, much higher risk currently taking it, and if you stop taking it, that risk will go down. So it is from the medication, or we believe it's from the medication. And again, the longer you've been on it, the higher the risk, okay, versus short time being on it, and where we would think there would be a higher risk. So what does this tell us? This tells us that yes, people are tolerant to medication. It is something that happens, but that does not take away our risk of incident, accidents, crashes, impairments, and safety in the workplace. So this is we've known this for a long time, we've said this for a long time, but this is a relatively new Canadian study that really hammers that home. So what do we do with this information? So what I will say to you is this. We talked about fitness for duty policies yesterday, and we talked about putting in their employees disclosing their medications that could be impairing or may be impairing to somebody so that you can then take a look and see. And again, if you specify which medications, you're inevitably going to miss something, because there are so many impairing medications that are not opiates, not benzodiazepines, not barbiturates, not the big ones that we think about, but that are highly, highly impairing. So we want to know what medication you're taking. We want to know, we're going to talk about half-life in a minute, so I'm going to skip over that, but that is something to know about the medication, but I'll talk to you about what that is in a minute. When are you taking your medication? Is it a long-acting? Is it a short-acting? I don't want to just know it's oxycodone. I want to know which formulation. I don't want to know that it's hydromorphone. I want to know if it's hydromorphone contin, long-acting, or short-acting. If you're taking pregabalin or a sleeping medication, I want to know the dose of it as well. How much are you actually taking of it? Is it the high end of the dose or the low end of the dose? Are you taking it at night only? Or are you taking it 3 times a day? These are all really important. The other thing, and we talked about this yesterday as well, again, is that with impairing medications and multiple impairing medications, 1 + 1 does not equal 2. Meaning we don't just add up the impairment of one and add up the impairment of the other one, and then that equals what it equals. When you take 2 or 3 or 4, and sometimes, trust me, the list is even longer than that, impairing medications, that risk is significantly more than each of the individual ones added up together, because they interact with each other. There's a number of different reasons for that, but just know that once you start seeing more than one impairing medication, then there's a real big problem. So I just took a look at an individual the other day and literally was on 7 different medications, not opiates. Opiates were not even one of them. 7 other different medications that were highly, highly impairing. And you put all those 7 together, and we have a really, really big problem. So knowing what else you're taking is really, really important. Looking at that whole list of medications is really important. Again, we talked about non-impairing options, so have those been addressed? And what do they actually do? And again, because not all safety-sensitive jobs are created equal, and so we may want to take a look at what they actually do in comparison to the medication. Now, the other thing, and again, I know I reiterated this yesterday, I'm going to say it again. There is good data to support the fact that untreated medical conditions, or certain untreated medical conditions, are impairing. So chronic pain, anxiety, depression, obviously substance use disorder, I think none of us would even argue with that. So I'm going to leave that one aside. But let's talk about these other ones here. All of these conditions that these medications are treating, if they are left untreated completely, are going to be impairing. And so now we have to balance this. So it's kind of like it's like I'm saying to you, okay, well, these medications are all impairing, they can't work with it, but if they don't have anything, then they're going to be impaired in the workplace, and then they can't work either. So what is the answer? And the answer is to sort of balance it all out. But just to keep in the back of your mind that when you say to somebody, you shouldn't be taking your sleeping medication, and that they are not sleeping and they're sleep deprived, that may also be a problem in the workplace. So it's really trying to look at options that are safest in the workplace compared to what the actual condition is, and whether there are other options that would be better. So maybe there's a sleeping medication that has a shorter time frame of action, that we know that after 9 hours, for example, it's completely cleared from the body, and then they can use that, as opposed to some of the other ones that may not be out of your body for like 18 hours, truthfully. There are some like that, where you feel really groggy the next morning. So we have a couple different approaches that I'm going to talk to you about dealing with these. ACOM is the American College of Occupational and Environmental Medicine. They took a look at the literature, and this was before that new one that I talked to you about, but they took a look at the literature, because I think this was 2014, and they took a look to see, what is our recommendation with these medications in the workplace? What do the studies say with impairment? What do the studies say with risk of incident, accident, car crash, et cetera? And how do we manage this? And really what they found is that whether you're using it for a short period of time, so acutely, so for example, I'm having a real bad tooth issue and I need to get in to see a dentist, and then I have to have root canal, and I have so much pain right now, and until I can get my root canal, I need to take Tylenol 3s or Percocets. And that would be acute, short period of time. I probably think for that employee that once they have their root canal done, after a day or two, they're not going to need pain medication. But short-acting pain medication, not recommended for safety-sensitive jobs. Chronic, long-acting opiates that you've been taking for a long time, where you are, in theory, quote-unquote, tolerant to, also not recommended. So what do they say? How long do we wait? What do we do? Their recommendation is to wait for 90% of the substance to be eliminated from the body prior to working. So if they're taking for a short period of time, it's a pretty easy thing. Maybe take them out of their safety-sensitive duties until they don't take it, wait for it to be cleared, and then they're good to go. But in a person who's taking their medications or needs them on a regular basis, can we put them to work? Can we not put them to work? Can we figure out a way to make this work? And their recommendation is to wait for about 90% clearance. And I'll tell you in a moment how we figure that all out. Now, what they talk about here is that this is mostly opiates, but we need to be cautious about benzodiazepines as well. The reason why benzodiazepines are not listed with opiates is truthfully because there's not a lot of data and research out there, or there hadn't been up to that point, about safety of it, because it just hadn't been looked at. But we have pretty good evidence, or very good evidence from the last study that I showed you, that we really need to be worried about those as well. So what does DriverCheck say? How do we manage it? And there are many other agencies that use this as well. We wait till almost all of it is cleared out of your body. When I say almost all, we're talking what we call 5 half-lives. And I'm going to go through what a half-life is and how you figure it out in just a minute. So bear with me for a moment. But why is that important? Because there are variations. So if I randomly choose 10 of you, I put you up here, and I dose you with a medication, the exact same medication, exact same dose, you're all going to have different effects for a slightly different amount of time, and it's going to clear your system in a slightly different amount of time. It is not an exact science because none of us are exactly the same. And so if we wait for most of it to be cleared out, then even if you are a little bit slower to clear it, you've still cleared enough of it that we can say, you know what, you're safe. So we kind of take all of those variations into consideration when we talk about waiting for it almost all to be cleared out. So what does almost all mean? So a half-life, what is a half-life? Every medication and substance has a half-life, and that means the time it takes for 50% of that substance, medication, drug, et cetera, to be cleared from your body. So basically, you go from 100 to 50 to 25 to 12.5 to 6.25, et cetera. So you can see here that if we wanted to get to 90% clearance, it's going to take between 3 and 4 half-lives. Okay? What we talk about at DriverCheck and what many other people talk about for many other workplaces is we're going to wait 5 half-lives, because then about 97% of it is going to be cleared. You can see from here, if you count to 5 there, it's about 97% clearance. And again, that's mostly cleared. It's not 100%. 7 half-lives would be almost 100%, but we're pretty close. And we're pretty confident that if we wait that amount of time, that really we've gotten rid of the majority of the impairing part of the medication where we don't have to be worried from a workplace perspective. So every single medication you could look up and say, what is the half-life? Now, the tricky part is that sometimes the half-life will be noted as being a range. The half-life for this medication is somewhere between 5 and 13 hours. And then you're thinking, oh, okay, so what do I do here? Because that's a huge variation. Because again, it depends on person to person. But we want to take the longest because if we are talking about safety, we want to err a little bit more on the side of caution and safety than to assume that, oh, this one, you're going to get rid of it quickly. We're just going to go with 5. But the other thing that's really important is looking at breakdown products or metabolites of medications that may also be impairing. So let's just complicate this and just say we can't just look at the drug and the medication. We now actually have to look at how it breaks down in the body and what else can be impairing about that. And I'll give you examples in a minute. I think we went through all of this here. So an active metabolite. Benzodiazepines and opioids are the 2 most common medications that have active metabolites. And I am not expecting anybody to memorize this, know this, et cetera, but keep it in the back of your mind that if you decide, okay, you know what, I learned something, I know that when Joe tells me that he's taking morphine, that I can look up the half-life and tell him that, okay, you're taking this for a few days, we're going to keep you off work, and then we're going to bring you back, but we have to wait X number of hours because the half-life is this, and we're going to wait 5 half-lives, and then we know that you're going to be safe to return. But we also have to consider that there may be active metabolites. And so this is where you may, if you're not totally sure, you may want to ask somebody for help. Meaning, let's sort of figure out what those active ones are and what the recommendation is with respect to waiting and how long do they need to wait and how can I get this person to work or back to work or in the workplace if they need to take this, et cetera. So we're going to have a test on this. No, I'm just kidding. This is the breakdown products of opioids and what those active and inactive metabolites are. So, what I will say is that it's complicated. The only reason I put this up here is to tell you that it is not a simple solution. It is not a simple thing that you can just sort of necessarily figure out, although sometimes you can. And so I put this up here just to remind you that things break down to other things that sometimes are even more potent or more concerning than what the original medication is. So codeine is an example. Codeine breaks down to morphine. Well, morphine is a stronger opioid than codeine is. And so when codeine metabolizes or breaks down to morphine, morphine is maybe a bit more of the problem than codeine is. And so we want to then look at what is the half-life of morphine and how long do I have to wait for that codeine to leave the body. So, in all of this, I'm telling you that you are not alone. You do not have to do this all on your own. It's just that if you have a medication disclosure policy, or people are coming to you to say, hey, look, my doctor wants me to take this, can I take this in the workplace? It is not just about, are they going to test positive? I often will get the question, hey, can you take a look at this? This company wants to know if this medication will test positive on a drug test. Whatever it may be. Valium, let's just take Valium. Well, they don't test benzodiazepine, so I'm going to say no, they're not going to test positive. But, that is not the issue here. The issue is that if this is safety sensitive, Valium is a highly sedating, highly impairing medication, so we need to look beyond the drug test and look at whether or not they're going to actually be safe to do the job, not just whether or not they're going to test positive on their drug test. Let's see, did we go through everything? Okay, so I think we talked about the risk and the balance because, again, we have to balance out whether or not untreated is going to be more of a problem than treated, and how long are we going to wait for, and how are we going to sort of negotiate it. And sometimes it is a bit of negotiation. It is about looking at, okay, what is this medication, and maybe the person has tried absolutely everything else. And maybe, truthfully, their pain, anxiety, depression, whatever it is, gone through therapy and treatment, and they're doing exercise, and they're doing their yoga, and they're doing their meditation, and they're doing their therapy, and it's not working, and they've tried 1,000,001 other medications. The only thing that seems to be helping is if they take something at night. And that night thing is impairing, but let's weigh everything. Let's see how long it lasts. Let's see what time. Maybe you could take it at 8 o'clock at night so that by the next morning, we've mostly cleared it out. So there are ways to sort of take a look at all of this. It doesn't mean that nobody can ever take any medication ever in the workplace. It means that we have to look at when you can take it, how long it's going to last, when it's going to be out of your system, and when you're going to be safe. And as I said, we have a couple different ways to look at it, whether it's 90% or 5 half-lives, 97%. 5 half-lives is what we recommend, because then we can really say that they're safe. But there are times where we may need to balance that out and take a look at it. Why is this all important? Obviously, if there are substances that are impairing, we're going to be at risk for accidents and incidents. Drugs and impairing medications that remain in your body and go to your brain and cause impairment can be a problem in the workplace, similar to cannabis. It's no different. So, I will often speak to people and they'll say, Joe is on hydromorphone, long-acting, and short-acting, and takes pregabalin, which is a non-opiate pain medication, and takes baclofen, and takes a sleeping pill at night so that he can sleep. And now he's coming to me and says he doesn't want to take all those medications and he really wants medical cannabis. And there's no way he could have medical cannabis in the workplace. And I'll say, so you're telling me he was using all those other medication while he was doing that same job? That's a problem. So as much emphasis as we put on cannabis, medical cannabis, recreational cannabis, and substances, we need to put the same thing on our medications. It is not okay to say, well, your doctor prescribed this and therefore it's fine, but cannabis is not really a prescription, it's an authorization. It doesn't have a drug identification number, and that's not okay. But the list of 20 different sedating medications that are highly impairing, that we have really good evidence to suggest that are very high risk in the workplace, very, very high risk of accidents and incidents, are okay, just because the doctor said that they could take it and they're prescribed and they have a DIN number. So we need to put all of these impairing medication substances together in a pool and not treat them any different, because they're not different. The risk and safety is there. And again, just because it has a DIN number and it's legal and they're taking it as prescribed does not mean that it is safe. Again, we talked about tolerance. The other thing that I really, again, this is like that take-home thing. I will guarantee that if you send a letter to the doctor with the 12 different medications that Joe is taking and you say, is Joe safe to work? Guess what he's going to say or she's going to say? Oh, absolutely. They don't abuse their medications. They never come in early for refills. I have no concern about Joe in the workplace. Okay, so that may check your box where you feel like, okay, so a doctor said they're fine, therefore they're fine. Please do not take that as meaning anything other than Okay, maybe they don't come in for early refills, or maybe we don't have to worry about addiction. But that does not mean that they are not impaired. Again, in medical school, we learn nothing, not 1 day, not 1 hour, not 1 minute of workplace safety. That if you ask doctors what it means, unless you're in occupational medicine, but if you ask a general family physician or a healthcare provider in general practice who's never worked in anything to do with workplace safety, occupational medicine, they have no knowledge, none, absolutely none. Asking the family doctor to say whether or not they are safe is like asking the mailman if they think the person is safe, because, you know, I don't know. And I'm a physician. I did family practice for a long time. So it's not that I'm putting them down, but it is all about you need to ask the person that actually has the knowledge and information to be able to give you a proper answer, a knowledgeable answer, an answer that considers everything that is there, the impairing aspects, the multiple medications, the time frame that it lasts, the half-life, and looking at the duties of their particular position, whatever that may be. So all of these things are what we have to take into consideration. You know, having a medication disclosure policy is really important because, again, just because it's prescribed, just because they're taking it as they're prescribed, and even when their doctor is the one who suggested it and said, it's okay, like I know you work in whatever, even if they've told their doctor what they do, and the doctor says, well, I'm not going to give you an opiate, but instead I'm going to give you 5 different other medications that are highly impairing and sedating, and we know have high risks. You know, I had some doctor who said, oh, I never ever give medical cannabis, but instead I'll give Sesamet. Sesamet is a prescribed synthetic cannabinoid medication. It's a prescription with a DIN number. It is way more potent and way more impairing than cannabis from a plant. So again, you know, it's about putting all the knowledge together and really asking someone that you know. So if you need to, there are programs out there, there are physicians out there, there are IMEs that you can do, and DriverCheck does have what we call a medication review program. So if you were to say, hey, I just have a quick question, is this a medication that I even need to worry about? Sometimes I'll get questions like, this person told me that they're started on a medication for their depression, and I'm a little worried after the talk that you gave that maybe it would be impairing. And you know, it's a quick email back just to say, no, we have nothing, like that's okay. Once they're stable on their medication and they don't have side effects, we're okay. But sometimes we may say, you know what, that could be a problem. We need to look into it a little bit more. So there is help out there. DriverCheck does have programs that can help you, and sometimes it's a very, very quick email. But when you're asking whether they're going to test positive on a drug test, also ask if it's safe to be used in the workplace, because that's a equally, if not way more important question. All right, so bottom line. I think we went through most of these. Even if it's prescribed, even if they tell you it's fine, even if it's a prescription, it may be a problem. Opioids and benzos are used in the workplace. They do have higher risk, but there are still a number of things. We want to wait at least 90%, but really much more carefully 5 half-lives or 97% until the substance is out of the body. And just don't assume that because it's prescribed by somebody and they know what the person does, that it is safe to use. So thank you. I know it was a lot of information. As I said, I'm hoping I didn't give you more anxiety than you walked in with, but thank you.